I'd like to explore something about the characteristics of different types of pain, because this does have a fundamental impact on the treatment options and indeed on the impact of different types of pain on individual patients. Let's look in this module then at the characteristics of different types of pain. There are several different types. You might think that nociceptive pain and inflammatory pain were overlapping. They are. But all of these elements are, to at least to an extent, distinct. So we can classify pain as the classic pain. You stub your toe, you bash your head. That is nociceptive pain. Then there is the inflammatory pain. Again, the inflammatory conditions, classically spondylosing arthritis or psoriatic arthritis, rheumatoid arthritis. Many of these have an inflammatory element to them. Neuropathic pain, of course, arises from the nerves and is treated in many respects by different treatment modalities, more effectively some than others. And then visceral pain, which can be a particular challenge, for instance, with patients suffering acute conditions such as acute appendicitis, but also chronic conditions such as irritable bowel syndrome. So nociceptive pain is the textbook pain, if you like. It has a positive function. It teaches us to try and avoid that stimulus or to remove ourselves from the cause of that stimulus as quickly as possible. Classically, it's sharp, stabbing, or shortly thereafter, it is throbbing immediately after the event. Usually an identifiable lesion, tissue damage, stimulation of nociceptors, and then somatic or visceral structures will take those messages to the spine, to the dorsal horn, up to the brain, where they are perceived and interpreted. Inflammation is a bit of a curate's egg where adaptation is concerned, good in parts. So it's distinct from nociceptive pain in as much as the underlying pain stimulus, the activation of the immune system by tissue injury or by infection, is different. In that case, how is it helping? Well, if you think about, say, a patient with a sprained ankle and the general advice that we give to patients following acute strains and sprains, price is the standard recommendation. So to encourage recovery, we're advising patients to protect, P, the injured area from further damage, and R, to rest it at least for 48 to 72 hours. So in fact, with this inflammation going on, the heightened sensory sensitivity which results from inflammation is effectively doing both of those things for you. It is encouraging the patient to protect the inflamed area and encouraging the patient to rest. But of course, there are times when it's decidedly maladaptive. Think of patients with ongoing inflammation, whether it's psoriatic arthritis, rheumatoid arthritis, or indeed in patients who've got severe or extensive injury. In those situations, we need to work to reduce that pain. Neuropathic pain is pretty much always a severe form of pain. Indeed, toothache, the treatment of acute toothache, is one of the classic ways to check out the efficacy of an analgesic for acute pain. So whether it's banging your funny bone, whether it's agonizing toothache or sciatica, whether it's diabetic neuropathy. Trigeminal neuralgia, where patients cannot go outside because the slightest wind brings on their pain. Or the patient of mine whose entire life, pretty much since her retirement, has been defined by and controlled by her post-herpetic neuralgia. It is also surprisingly common. Up to 1 in 12 adults have neuropathic pain at any given time. Now, it arises from damage or injury to the nerves, to the spinal cord, or to the brain. It's often burning or shooting, and it may be associated with hypersensitivity, either to touch or to temperature, or indeed to both. worse still perhaps, patients often report spontaneous pain. And this to them is sometimes perhaps the most distressing because they don't understand it. There is no obvious peripheral stimulus. And of course the pain may be either paroxysmal or continuous. It is also very frequently chronic, and indeed it may escalate over time. In addition, it is extremely challenging to manage effectively, really challenging to diagnose. But the issue here is that there is a need to rely on treatments which target the central nervous system with all the central side effects that bring. So the side effects indeed for many patients can be hugely debilitating, if very different to the impact of the pain on their lives. Neuropathic pain is also characterized by evoked pains. It is a pain which impacts directly on the nervous system. So allodynia, a painful response to what should be normal touch. Patients who can't bear to be held. Hyperalgesia, pain of abnormally high severity following what would normally be a noxious but perhaps only a mildly noxious stimuli. Hyperpathia, the exaggerated, the prolonged response to stimulation. Hyperesthesia, the increased sensitivity to stimulation. And the one that perhaps they find most difficult to understand, this dysesthesia, this evoked or spontaneous altered sensation. In every respect, neuropathic pain is a challenge regardless of the underlying cause. Visceral pain is a challenge for very different reasons. It arises, of course, as we know, from internal organs. But by comparison to somatic pain, it is often very diffuse and very poorly localized. We know that there is a low density of visceral sensory innervation. That sadly does not mean pain is less keenly felt. It is simply a question of finding it harder to pin it down. There's also, of course, excessive divergence of visceral input within the central nervous system. So it is often referred. We all know about the patient with shoulder blade pain which is coming from diaphragmatic irritation and so on. But in addition, the autonomic responses is often a major element in the response to visceral pain. So pallor, sweating, diarrhea, vomiting, nausea, blood pressure, heart rate, all disproportionately affected by visceral as opposed to other kinds of pain. Chronic visceral pain. It is a huge challenge, and in the vast majority of cases, it is a challenge for women. So is it just dysmenorrhea? I have patients later diagnosed with endometriosis who get so angry at being told that it was, quote, just dysmenorrhea, because even if it was just dysmenorrhea, it does not stop it from being hugely debilitating. So chronic and recurrent visceral pelvic pain is vastly debilitating. It is poorly understood, and unfortunately, that means that sometimes doctors, because they don't understand what's going on, they may perhaps be tempted to make an assumption that this is subjective and that this is not something to be taken seriously. Pelvic inflammatory disease, endometriosis, adenomyosis, pelvic adhesions, ovarian cysts. We tend to think of fibroids, very, very common, but we tend to think of them as causing heavy rather than painful periods, but they can cause pelvic pain as well. All these factors are very often not limited to the time of the woman's period. Endometriosis, of course, the pain tends to become worse around the time of the period, but it can extend both before and after, and indeed across the entire of the menstrual cycle, and the pain can radiate to the thighs, to the buttocks, to the abdomen, to the back. This can become all-consuming. Irritable bowel syndrome is another condition which can consume patients' lives, and it is another condition which is felt more commonly by women than by men. The incidence is higher among women. But again, it's a typical visceral pain. It's poorly localized. The pain is colicky, comes in spasms. It's often relieved by opening your bowels. Interestingly, though, it's not just about this subjective phenomenon. So, yes, there are subjective symptoms, pain, but also nausea, tiredness, anorexia, and headache. But there's also often objective evidence, increased wind, constipation, diarrhea, a combination of the two, pellet-like stools, and passage of mucus. Now, interestingly, it is more common in women, but if we look at studies looking at rectosigmoid stimulation, there are distinct sex-related differences in responses to certain sympathetic nervous system stimulation. So yes, there may well be a very real reason this is not just women, nor indeed is it just IBS. One of the things that people with IBS find, I think, perhaps most distressing is when the doctor says to them, the good news is it's only IBS. What they mean is you don't have colorectal cancer. But when you're in that much chronic pain, that is scant comfort. So, in the end, the source is less important than the impact on the patient's life. Acute pain can become chronic, and the mechanisms involved of central and peripheral sensitization are similar regardless of the type of acute pain. The key for us, and ultimately for our patients, is to identify, to treat early, and to prevent chronic pain from developing. So in summary, there are four main types of pain. There is nociceptive pain, the one we all think about, the one our patients think about. You bang your thumb, your toe, whatever. It serves a purpose. It is generally adaptive in an evolutionary sense, and indeed, even today. Inflammatory pain, as we heard, can be adaptive in some respects, but it can also be maladaptive. Neuropathic pain is a real challenge to diagnose, and because of its location and therefore the need to use drugs which target the central nervous system, can be particularly challenging to treat. And visceral pain, well, yes, there aren't that many nerve endings in the viscera, but that does not mean that people don't feel pain. They just feel less able to localize it, and indeed it has exaggerated autonomic responses. So understanding how these differ, both in terms of the presentation and indeed in terms of the treatment, is key for us and for our patients. And also key is preventing acute pain from becoming chronic. So in summary, pain is subjective, but even though there are multiple factors which determine pain perception, that absolutely does not mean that we should ever underplay the impact that it is having. There are four main types of pain, and each of them has unique characteristics. Each of them has functions, some adaptive, some maladaptive, some somewhere in between. But they also all have their own challenges, both in diagnosis and treatment. The real key is to identify, to treat, to manage acute pain, and therefore, by doing so effectively, and by modifying modifiable risk factors, to prevent the development of chronic pain.